Es un placer para mí estar hoy aquí, en este Congreso de la Sociedad Española de Vaccinología. Lo siento, pero mi español acaba aquí. I think I don't need to tell this audience that prevention is important, but I certainly would like to start with this. And I guess the second concept I want to start with is that there are billions of species of bacteria and viruses. We are all nothing but the nice wrapping for 95% bacterial cells that we carry around. So I consist of 95 bacterial cells and only 5% human cells. So I think prevention is important because there are many more. If you go to the Douglas Mandel textbook of infectious diseases, you will see, yes, there are millions of species, but in the end, if you count them, only 275 do cause disease in humans. So the good news is we as infectious diseases people just need to know 275 species to make a living. And we can go even further and we can look according to age. Very few organisms age appropriately cause disease. And there is one organism that is a little bit outstanding there, maybe two or three, and it's the capsulated bacteria, Haemophilus, Neisseria meningitidis, and Streptococcus pneumonia. I would add influenza here as well, because influenza causes disease here and also in the elderly, and the same is true for the pneumococcus. Why is the pneumococcus so important? The pneumococcus is so important because today this organism is the #1 cause that causes death that can be prevented. So all the others, we have vaccines for quite a while, particularly to measles. It's not used well. There are still outbreaks and so on and so forth. But this is where a lot of disease is still around. And despite the use of antibiotics and despite of the use of polysaccharide vaccines since the 1900s, nothing has happened. So we are there where we were at the beginning of the 20th century. There is still a lot of pneumococcal disease out there and nothing has changed. So how can we do better? You have to understand something about the pneumococcus. It's a gram-positive diplococcus. The polysaccharide capsule is a virulence factor. It defines the serotype. There are 93 serotypes. That is bad news because if you want to develop a vaccine, you have some problems there. But in the end, very few serotypes cause most of the disease. Now, the capsule is important. The one aspect, it's a virulence factor. And it is important as a virulence factor for two reasons. Number one, it prevents killing by the white blood cell. So the capsule is like a shield. The granulocyte cannot kill the pneumococcus. The polysaccharide, this sugar capsule is also important because it allows colonization. So organisms use the capsule so that you are colonized. Actually, it downregulates your immune system. The polysaccharide is really immunologically important because it reduces your immune system, and this is why the organism can colonize you. And I guess I start here also by telling you right now, a polysaccharide vaccine cannot be a good vaccine because it helps the organism to downregulate your immune system and it's responsible for colonization. And I come back to that again at a later point. To understand the disease, I want to start with the steps that are involved in the pathogenesis of the pneumococcus. The first step is colonization. Very clear, no colonization, no disease. A vaccine that is highly effective will prevent colonization. And I can say it right here and will show you later. The polysaccharide vaccine cannot reduce colonization because it uses the capsule, which helps the organism to colonize. The conjugate vaccine reduces colonization, and this is why it is effective against a wide array of diseases. First step, colonization. From there, direct infection of the middle ear, otitis media, or of the lungs. Pneumococcal pneumonia is aspiration pneumonia. The organism goes from your nasopharynx down to the trachea into your lungs, and then you have pneumococcal pneumonia. You drink too much, you aspirate, you have pneumococcal pneumonia. You go to surgery, the anesthesiologist takes the tube and puts the pneumococcus down into your lungs, you have pneumococcal pneumonia. That's the pathogenesis. Very rarely, the organism can go directly from colonization to the bloodstream, and then you have septicemia or bacteremia. Very rarely from otitis media. 5 to 10% of all pneumonia cases, the organism goes into your bloodstream. And from the bloodstream, the organism can go to your meninges or to your joints, and then you have meningitis and arthritis. So again, the pathogenesis, the first step is colonization. No colonization, no disease. And then the different steps, and I guess we can summarize this. There is IPD, invasive pneumococcal disease. This is bacteremia, septicemia, meningitis. And then there is local disease, which is otitis media and pneumonia. Very important to differentiate, because later on we come to the relative importance of invasive disease and of pneumonia and otitis media. Now, this is a talk for those of you in everyday's practice. I want to be very practical. I will tell you what are we talking about, the background of pneumococcal disease we've started already. I will now show you the burden of disease. I will show you the vaccines, and I will show you what you can do about it. This is now the incidence of invasive pneumococcal disease, and what you see here is the frequency, the incidence is high early in life. This is the red line. In infants, 150 per 100,000. It goes down with age, and it goes up again with age. Mortality is comparatively low in infants, and it goes up again with age. So it's an important disease, as I said before, early in life and late in life. This is invasive pneumococcal disease, IPD. The second point I want to make here is IPD is, well, important because it's a severe disease, but pneumonia is much more frequent. This is actually pneumococcal cases and death from the United States, those above 50 years. 500,000 American subjects 50 years and older die every year have pneumococcal pneumonia. So if you want to prevent a disease, it's nice to prevent IPD, 30,000 cases, but pneumonia is 17-fold more. And the same is true for death. Pneumonia kills more people than IPD. This is the thing to remember. So what you're really after, if you want to vaccinate against the pneumococcus, you're after pneumonia. You care about IPD. It's important because many people die. 10% will die from IPD. If you are 80, 85, even higher rate will die. But pneumonia is really where the big burden of disease is. Now, it's difficult to diagnose pneumococcal pneumonia. If you're in private practice, you have no chance. If you do a study, and consistently all over the world, if you look for community-acquired pneumonia, a pneumonia that is acquired outside the hospital, then what we know from all studies that have been done around the world, roughly 1/3 of all cases is caused by the pneumococcus. So very often you will hear CAP, community-acquired pneumonia, and you will not hear pneumococcal pneumonia, because this is difficult to diagnose, particularly in practice. So I talk very often now about CAP, and these are the other CAP organisms, influenza and whatever they are, but the most important one, again, is pneumococcal pneumonia, 30% of cases from a large series here. Many more data, consistently all over the world, 20, 40, sometimes 60% is the pneumococcus. Now we go to CAP, and I want to show you again, even if you go to CAP instead of pneumococcal pneumonia, it starts somewhere here at around 50, 60, and then with 70, CAP goes up. And I have more data here from other countries, the same picture everywhere. The important thing here to remember is IPD in children was 150 per 100,000. CAP is, you know, this is 40, 30, 20 per 1,000. So CAP is 100-fold more common. So whatever way you look or whatever way you're looking at, pneumonia is the important thing to prevent, and IPD is very important because it's severe, but it's 100 times less frequent. I mentioned that before. Pneumococcal polysaccharide vaccines have been around since the early 1900s. The first 23-valent pneumococcal polysaccharide vaccine was licensed in the United States in the year 1983. Penicillin was around roughly since 1945, after World War II. Mortality unchanged. And whatever new antibiotics we came up with, whatever new vaccines, mortality is unchanged. Different definitions of what you want to prevent, nothing has really happened. So we really have to do something. And being here, I guess the thing that we want to do and that we think about is vaccination. One other item to explain at this point is who is at risk for pneumococcal disease besides the very young and the very old. And this is a slide taken from the American ACIP. And they say there are immunocompromised subjects, immunocompetent subjects, and then there are external factors and behavioral factors, and they all increase your risk for pneumococcal disease. Again, this is age, and this is immunocompetent. Actually, honestly, this is not immunocompetent, but they list it as immunocompetence. They are Americans, and they are not quite precise with their language. So if you have diabetes, your white blood cells don't work that well, and your antibody production may be down as well. If you have no spleen, you have an immune defect in the end, right? So the primary disease that does not affect the immune system, but they are not immunocompetent. Likewise, smoking, I saw some outside smoking. We have a test for pneumococcal antibodies which uses white blood cells to kill the pneumococcus. If you take the white blood cells from a smoker, it will not do anything against the pneumococcus, let alone kill the pneumococcus. They love each other and they play with each other, but the white blood cells stop killing the pneumococcus. So my suggestion would be stop smoking as soon as possible. Anyway, this is the risk factors of the pneumococcus. Another way to look at the risk factors is disease incidence in healthy and in risk subjects. This is from a great American paper with a large database on Americans, done by a very nice colleague from the Centers for Disease Control. And he looked at this in the United States, and this is your incidence per 100,000 over time. But if you have diabetes, your risk is 4-5-fold higher. If you have chronic heart disease, it's even 10-fold higher. And the same is true if you have chronic lung disease, COPD, or whatever it may be. This is a similar database that was just published from the United Kingdom. Again, it's population-based. It's a huge database with everything they know about their patients in this government-run healthcare system. And they look at the risk for invasive pneumococcal disease in age groups 2 to 15, 16 to 64, and 65 plus. The incidence of IPD in this age group is 3.9 per 100,000, 5.2, 17.9. Now, your odds ratio, your risk to get pneumococcal disease at this point, if you have no risk factor, they say this is 1. So, I'm sorry, what happened now? If you have chronic lung disease, all of a sudden your risk factor is 12.7. The incidence goes up to 50, 16.8, 91, and here it's 5.1, but 91 incidence as well. So this is from a very large database, just to show you that chronic lung disease increases your risk in all age groups. So it may be a good idea to not only vaccinate the very young and the very old, but also those at risk. Now, the whole database is very complex, and don't worry, I won't go through this, but this is one table from this great paper. It's from Van Hoek et al., published in 2012. If you are into this, this is one of the papers that you should read to look for the various underlying diseases and their resulting increase of risk for invasive pneumococcal disease. The next two slides are just confirmatory data to show you that all other data show into the same direction. This is from CUPNet, 7,400 adults from 12 centers with CUP. Again, smokers and those with chronic lung disease, they have the highest risk to come down with community-acquired pneumonia. The previous one, the Van Hoek paper, this was invasive disease. This is CUP. This is now CUP data from a large hospital, from University Hospital in the United Kingdom. Again, chronic obstructive pulmonary disease, 1/4 of the pneumonia cases. Okay, so we know now that the one disease that is vaccine preventable and that causes most deaths worldwide is pneumococcal disease. It causes invasive disease and pneumonia. Pneumonia is the big chunk. It's much more frequent than IPD. And we know if you have a risk factor, you are at risk in all age groups. The risk may still be low, but you have an increased risk. Now, what can we do against it? And we want to vaccinate. And this is just vaccinology for beginners. What do you need to vaccinate? Number one, you need a muscle and a vaccine with a syringe, and you inject the antigen into the muscle. From there, an antigen phagocytosing cell picks up the antigen and takes it to the lymph node, and there is an interaction between the APC, the antigen phagocytosing cell, B lymphocytes, and T lymphocytes, and that results then in detail in the production of a plasma cell to produce antibodies and a memory cell to produce memory. So for a second encounter with the organism, you are protected. You get a quick and high antibody response. There are two types of vaccines against the pneumococcus: polysaccharide vaccines and conjugate vaccines. Now, the important thing to understand at this point is polysaccharides don't interact with T cells, and they don't result, therefore, in the production of memory cells. And this is another reason, I already mentioned a few, why polysaccharides are not good vaccines. They are far from being ideal vaccines. They work because you give very high amount of antigen. You give 25 micrograms per serotype, and you have 23 serotypes. The conjugate vaccine only has 10%. It only has 2 micrograms per serotype. So the polysaccharide just acts by giving a lot of antigen to this B cell, and you get plasma cell production and antibody production. And the antibody response is not very good, as I will show you, and there are some problems with it. Here I have data to show you if you're healthy, you have that type of antibody against the polysaccharide of the pneumococcus. If you survived pneumococcal meningitis, your antibodies are significantly lower. After 6 days, after up to 50 days, after 3 months, your antibodies are lower than those of healthy controls. The pneumococcus, the polysaccharide, downregulates your immune system. If you survive pneumococcal pneumonia, same picture, you have significant lower antibodies as compared to healthy controls. So the polysaccharide really is not a good vaccine. Actually, we use it, and it has, as I will show you later, it has some effect, but it does not produce memory cell, and there is no T cell response. Now, this is what happens. You give the polysaccharide. This comes in contact with a naive B cell. You see plasma cell differentiation. You see antibody production. And then if you give a second dose, there is no memory. And after a second dose, the titers are lower than after the first dose. And this is called hypo responsiveness. And I have data on this published for 6 pneumococcal serotypes. I just show you one. The picture, the pattern is the same. Before giving the 23-valent, you have a titer of roughly 7 micrograms per ml. You give one dose, it's almost 20. After a year, it's down. After 4 to 7 years, it's 4. Now, at 4 to 7 years, you give a second dose, and your antibody response goes up to 7 again, which is what you had here, but not what you had here. This is called hyporesponsiveness. There is no data to show that the second dose will have any effect in terms of protection. It's recommended in some countries, but there is no evidence to support this. Again, this is called hyporesponsiveness, and it results from the fact that there is no memory cell. no memory cell, and you've used your naive B cells, so only those naive B cells that are left for this antigen can help you. In the end, you get a lower antibody response. For those of you who are into immunology, there's a great paper from Clutterbuck and co-workers published in 2012 to show you that the 23-valent vaccine downregulate your B cell response, whereas the conjugate vaccines lead to an upregulation. Just for the immunological basis for what I explained before and what I will explain in a minute as well. Now, how about, this is epidemiological data. I had immunological data. Now we go to protection. Does the polysaccharide vaccine protect against pneumonia? This is the summary from a WHO-sponsored meta-analysis. And as you can see, some studies show clear protection against pneumococcal pneumonia, others don't. And those who are here in purple, they are better blinded, they have better concealment of allocation, who gets placebo, who gets the vaccine. And if you analyze this in details, you come to the conclusion, and this is the author's conclusion, not my conclusion. This meta-analysis supports the notion that further high-quality trials of the pneumococcal polysaccharide vaccine would fail to show any protective effect against pneumonia. And this is a WHO-sponsored meta-analysis. And you know, if WHO believes that this is true and allowed publication, then I guess even though Pfizer pays me, it's fair to say that this is the best available data today that we have for Ppv13 and pneumonia. I think, if anything, it doesn't do much against pneumonia. How about invasive pneumococcal disease? Does Ppv23 prevent invasive pneumococcal disease? Not the big chunk of disease, but some disease. A few weeks ago, in the United Kingdom, there was a huge meta-analysis, not a meta-analysis, a huge database analysis of all they have in their database on all subjects with invasive pneumococcal disease, 22,500 subjects with IPD, and according to vaccination status as of age 65. Now, what they look at is different age groups, 65, 75 to 84, above 85. And in each age group, they look 2 years after vaccination, 2 to 5 years after vaccination, and more than 5 years after vaccination. And for all these groups, they have analyzed the effectiveness of Ppv23. And don't worry, it's a lot of data. This is the numbers. To make it more simple for you, the red numbers are those where the 95% confidence interval includes the 0. This is minus 55 to 65, so that means no significant effect. So if you take out all the red, this is what is left. And what you can see right away, efficacy or effectiveness of Ppv23 after 5 years is gone. Efficacy of Ppv23 as of age 85 is gone. If you have no risk factors, I'm not sure how many patients you have in your private practice who are age 65 with no high blood pressure, no cardiac disease, diabetes, renal disease, or I don't know what. There are not many left, but those patients have a benefit for 2 years after vaccination and even for 2 to 5 years after vaccination. High-risk immunocompetent, 2 years they have, and then it's gone. And if you're immunocompromised, your risk of IPD increases. Your risk is minus 92%, which means it doubles, approximately. So this is significant less protection. This is a significant result. In the end, the overall reduction of disease is 24%, with no effect on mortality. So those who received Ppv23, the death rate was similar in the vaccinated as in the unvaccinated. And this is the largest database that there is out there. It's the whole England and Wales country. It's all that they have there. This is the largest database. And this analysis was published by the United Kingdom or by the England and Wales Health Protection Agency. And again, it's credible data. Conjugate vaccines are chemically conjugated polysaccharide serotypes with a protein. Now, if you use a PCV, the immune response is different. There is an encounter with B cells and T cells. You get interaction with plasma cells, and you get differentiation of memory cells. And you can give booster doses, because with your memory cells, after a longer period of time, you get a very similar antibody response. If you give your second shot here, you will not see much of a response, admittedly. If you've used all your naive B cells, and if they are still busy, or if they are still encountered with something else, they will not react much. But if you vaccinate here, there is a nice booster response. And this is all the difference. In addition to that, as we know today, conjugate vaccines reduce carriage. The mechanism is not well understood, but it is a T-cell dependent response. We know it's the T-cell. It's not the antibody. The mechanism in detail is not known, but it's very important to remember that conjugate vaccines reduce carriage. And this is very important if you want to consider a vaccination strategy in adults. If you have a lot of carriage, if you have a good coverage with a PCV in children, you get rid of the pneumococcus in children. And pneumococci are the reservoir. And if you take the reservoir, you get rid of the disease in adults. Only if you have high vaccination coverage, 80, 85, I don't know how much percent. This is now to prove this. In the United States, the incidence of IPD in children under 5 years was here 80 per 100,000. You introduce the vaccine, it goes down to 4 per 100,000 within a few years. These elderly subjects, age 65 and older, have not received the vaccine, but the incidence is reduced by 65%. It has been calculated that for each case you prevent here, you prevent 2 cases here. That makes sense, because each child has 4 grandparents. 2 of them are never there, they have died or don't visit the family, whatever the problem is. So they are in contact with 2, and those 2 won't get the disease. Very simple story, right? But this is a very cost-effective vaccine. If you have a high coverage here, like in the United Kingdom or in the United States, this is what you will see. Now, admittedly, for the pneumococcal conjugate vaccine, we don't have efficacy data in adults. We do have efficacy data in children, and this is from IPD for the 7-valent vaccine, 97% pneumonia, all pneumonias, community-acquired pneumonias with all organisms, 35% reduction, otitis media, 57% reduction. So this is good news. And I guess the main mechanism of action for pneumonia and acute otitis media for this vaccine is reduction of colonization. If the organism disappears from your nasopharynx, you're well off because you cannot get direct infection. And I guess that's at least to some part due to reduction of carriage. Now, let's go back from children to adults. In adults, we don't have efficacy data. We do have immunogenicity data. And this is one summary slide. I don't want to go through the 562 serology slides that Pfizer has on PCV in adults. I just want to show you this one. The red line shows the vaccination with a polysaccharide. You start with dose 1, you get a nice antibody response. It goes down over 3 to 4 years. You give a second dose, you get a nice response, but it's lower than before. We've seen that before. Now let's go to the gray line. You give 13-valent to 30-valent in those 60 to 64 years old. And what you see here, you get a higher antibody response. It goes down, and it goes up again. You can also give, and this is this awkward color here, I'm not sure if it's gray, orange, or whatever it is. You give the 13-valent and then a 23-valent booster dose. So you start here, you get a nice response, it goes down, and you get a very nice response thereafter. So the polysaccharide works as a booster because you have memory cells. You have induced immunological memory, and that's the proof. You get a much higher antibody response. Now, this one is the best response of all. You have to be 10 years younger, 50 to 59. The younger you are, the better the response. 50 to 59 gives you a better response than 60 to 64. I'm not yet 60. I never know how to call this age group because I'm in here. I got the vaccine as soon as it was licensed in the Philippines. I happened to be there, so I got my shot. It was for free. So I thought it's a good idea to get it now, right? So I'm here in this group. I'm very happy that I got this high, but honestly, I have no idea what the high titer means. Am I better protected than those who get it at age 64? I have no idea. Nobody knows. So it's just to show you there is a lot of immunogenicity data out there. The short story is you see what you expect. You get a nice response with the polysaccharide, which is non-inferior or higher as compared to the 23-valent polysaccharide vaccine. We also have data on subjects with underlying diseases. This in black is all subjects with and without underlying disease. This is chronic pulmonary disease in this light blue. This is cardiovascular disease in this gray, and diabetes is blue. And what you can see for the 13 serotypes, the antibody response is the same. If you have diabetes or COPD, whatever it is, the antibody response is roughly as good as if you are healthy. There are data, or we have a study to show that you can give Pcv13 along with influenza vaccine. This was the study design, double-blind randomized. All subjects received 2 shots with influenza vaccine plus Pcv13 or Pcv13 plus placebo, and then it was just the other way around 2 months later, 1 month later. I don't show you the data. It's in the license. You can co-administer at the same time Pcv13 with influenza, with TIV, with the annual influenza vaccine. Let me go again to immunology and immunological responses and age. This is a study. It's not one study. It's many studies where we looked at all the data we have from 6 weeks of age to, I think the oldest subject we had in a trial was 90-something. I forgot the precise age. So we start with infants, 3 doses, and after 3 doses in infants, you get this titer. 3 doses, and you don't get that much. Look here. Post-toddler dose, after the dose in the 2nd year of life, that's really nice, right? Much higher. This one already protects. So the good news is after 3 doses, these children are protected. And after the toddler dose, you're probably, I guess, I hope, you're protected for life. We know it protects for 12 years. We have 12-year experience to date. Now, if you're 6 to 11, you get this response. And if you're 12 to 18, you get that response. The older you get until you're 18, the better is the immune response. And these subjects have received only 1 dose. They've received 3 doses. Now, once you're 18, then that is the sad picture I tried to tell you before. Everything goes down, right? But, you know, immunologically, we age, let's be optimistic, we age as of 30. This is the titers you get, and then your immune system goes down. 1 dose, and your immunogenicity gets lower. I just want to show you that the immune response largely depends on age and how many doses you need to give and so on and so forth. And I guess what you can summarize is the reservoir of the pneumococcus is the very young. Carrier rates are extremely high. Depending on population, it may be up to 80%. I guess in other countries it's 40, 30, depending on kindergarten, daycare, whatever. You know, this is where the organism is. Another reservoir is animals. It probably doesn't play a role. I'm not sure if you have a dog or a cat. I would not be aware of any data that would increase the risk of your child for pneumococcal disease. But definitely, the reservoir of the pneumococcus is also animals. We know that. But we don't know what that means for humans. And the young babies give the organism to the adults. Now, the immune function is very low here, somewhat lower in the end of age, and it's very good once you're 20 to 30. And that means you get your disease when you're very young and when you're very old. And this is why it makes sense at this point in time to vaccinate here, the very young, and the very old, unless you have herd protection. If you take away the reservoir from children, then you will take away the disease here. So the big question is, we have two types of country in the world. Those with 90% coverage for Pcv13 in young children and those who don't. And they need different strategies for elderly. Let's talk very briefly about side effects, because this is what adults worry about. And I think Magda knows this, smiles, and Carlo knows it as well, but I love to use it because adults are afraid of side effects. Babies don't worry about it, apparently. This is a comparison of Pcv13 and Ppv23, roughly no big difference. This difference here is probably due to the fact that these subjects in red have received a polysaccharide dose before, so this is the second polysaccharide dose, and then you see more reactions. So, you know, this was redness, and this is swelling now, so not much to expect. If you look to local pain, everybody has local pain after injection. So overall, if you talk to people who've received Ppv23 or Pcv13, they will say, yes, you know, I had some pain, redness or swelling, but largely it's well tolerated. And if they know about the pneumococcus, they would be happy to get the vaccine again if they hadn't received it in the past. So this is nothing to worry about. The same is true for systemic events, basically nothing to worry about. The polysaccharide conjugate vaccine may have some advantages here with regard to some of the general reactions. Decreased appetite is less and muscle pain is less, whatever. I'm not sure if this is relevant. In the end, the tolerance of the conjugate vaccine is really very good, and we had no problem with that in our clinical trials. Safety is always a concern. Safety means, does a vaccine cause another disease, or does it cause permanent disability? We have had in clinical trials more than 200,000 children to date in a database with clinical trials. And we have a big study going on with 80,000 subjects in the Netherlands in adults, 65 plus, and half of them received the vaccine, and there is no reason for concern for safety. We've had 6,000 additional subjects in phase 2-3 trials. We've sold worldwide more than 500 million doses of Pcv7 and Pcv13, and nothing to worry about, no safety concern. So from all we know, the safety profile of our vaccine is excellent. You never can say a vaccine is safe for various reasons. You cannot say it because there may be a criminal who exchanges the vaccine and puts something in there that shouldn't be in there, and then, you know, whatever you administer is no longer the vaccine, but you give it and you believe it's the vaccine, and there is some severe adverse event. And actually, that happened to polio vaccination in India, where some criminals took away the OPV and exchanged it to the wild virus, and a couple of children were paralyzed. So, you know, it never can say a vaccine is safe for various reasons, but to date, we have no safety concerns with Pcv7 and Pcv13. Now, if you want to be successful with vaccination, then we have to look at the evidence, we have to come up with the money, we have to look for cooperation, and we have to make sure that the vaccine is accepted. I showed you all the data on the epidemiology of the pneumococcus, the most important set of data. I showed you the immunological basis for the conjugate versus the polysaccharide, and I showed you data on the responses and on the safety and the adverse events. Financing is certainly something that has become very important these days, and I totally understand this. Wherever you go these days, whether Germany, Singapore, or any other rich country, this is always a topic. You have to come up with the money at some point. And finally, what I want to talk about a little bit is cooperation to get it done. If you have a vaccine, the first thing that you are after is a license. No license, nobody can use the vaccine. The second thing is you need a recommendation. And it's nice to have a recommendation, but what you really want is reimbursement. In addition to that, once you have a license, you may be a scientific society for the elderly, for those with lung disease, for those with heart disease, and you may say, it's best practice to give this vaccine, once it's licensed, to everybody who has COPD or chronic heart disease or whatever it is. So this is scientific societies. They come up with best practice recommendations. They don't pay, but they have a recommendation. And finally, the patient may have an idea if he wants to be vaccinated or not. And you are in place of the patient, and you have to decide, if I were the patient, What would I want to have? And then you can make your decision. What would work here and what would you recommend to the patient? Right now, what most people are looking at is recommendation and reimbursement. And I have some data on this one. The point that I want to make with this slide here is there is much more we can do, and we simply don't do it because the patient will have to pay for it, and very often we say he won't pay for it. Now, this is just to show you, even based on the same scientific data, the label of the Pcv13 is different in the United States and in Europe. In the United States, we agree on the label in children and in adults that Pcv13 prevents IPD. We have no indication for adults for Pcv13 against otitis media. It's a rare disease here, nobody's after this, right? But pneumonia, in the US, we have a recommendation. In Europe, we don't. Otitis media, the American FDA says Pcv13 will prevent otitis media due to the 7 serotypes in Pcv13. There is no data on the additional 6 serotypes. And in Europe, we say it will all work. The same evidence, exactly the same data were submitted, and scientific advisory boards come up with different recommendations. The thing to tell you is recommendations are based on history, on politics, on thinking, on values, you name it. You can see it positive or negative, we have to live with it. But the same science comes to different conclusions from government boards or from government societies. And I think it's okay. I have no problem with it. We live in a global world and people have different views. And as a scientist, I can support all these views with good arguments. But you have to make a decision. Now, how do you get a recommendation for the sake of fun? This is how we come to a recommendation in Germany. I have more countries. The most difficult one to understand is Australia. It would take me 3 slides, so I didn't take that one, to explain you how you get a vaccine recommendation or vaccination recommendation in Australia. Germany is quite uncomplicated there. I'm not sure how it works in Spain. I have no idea. But it's difficult. It's very difficult to come up with recommendations. And to summarize, the evidence is the same globally, but recommendations differ. There is now a scoring system called GRADE, and if you score, it makes everything more transparent, but you still come to different conclusions. Besides, Germany has the grading system, the ACIP has the grading system, and they recommend something totally different for Pcv13. GRADE is not universally applied to all vaccines. Recommendations should be based on goals, and I think this is the important point. What do you want if you give an adult patient a pneumococcal vaccine? Do you want to prevent pneumonia, IPD, or both, or why do you give it? I think I don't need the grade system. I need the evidence. It has to be clear, and it has to be good evidence. And then I need to decide which goal can I reach with my recommendation. And now you have to decide Pcv13 or Ppv23 or nothing, or antibiotic once the person has a flu, or what do I do? This depends on your goals. Now, we do have for Pcv13 already recommendations and reimbursement in 16 European countries on various levels, funded national, funded regional, funded national. I understand Spain should be up here for your high-risk recommendation, so you should be in the dark green part up here. I could change it here, but I was unable to bring it up here. In any event, what you see again, all over Europe, based on the same data, you get different recommendations from government advisory board, and the same is true for scientific advisory boards, but these recommendations are already out there. This is the American ACIP recommendation. Again, I don't want to go through this. It's quite complicated. It was published a couple of weeks ago in MMWR, in case you're interested. It's based on the assumption, or based on their hope, and I think within 2 years it will come true, that in the United States, the Pcv13 serotypes will disappear due to large coverage rates in infants. So they don't need the Pcv13. If those 13 serotypes have disappeared, you don't need to vaccinate your 65 plus or 60 plus subjects unless they travel to places where there is no program with Pcv13. To summarize, pneumococcal disease is the most common preventable cause of death. The burden of disease is high above 50 and in the very young, and in those with chronic diseases, all types. There are 2 different vaccines out there. The difference is T-cell response, boosterability, efficacy in children and HIV-positive adults. I didn't show you that set of data. And finally, you have to decide if you want to have no recommendation, an age-based recommendation, or a risk recommendation. Whatever your recommendations are, all bodies recommend that Pcv13 is given before you give Pcv23. I mentioned that we have a large efficacy trial ongoing. It's called CAPITA trial from community-acquired pneumonia, and 85,000 subjects are randomized to receive placebo or Pcv13, and I guess the end will be hopefully by the end of next winter. If we have a severe influenza season, it will work, and then we will have efficacy data on pneumococcal pneumonia from this large trial. Now, the thing to do is to use the vaccine in the right way. If you want to prevent the sun from shining into your eyes, you have to use the cap and you have to use it in the right way. And the most important thing is, whatever your decision then is, you have to treat, to prevent, you have to give the vaccine to make it happen. Thank you very much for your attention.